Well, let's look at some questions that colleagues have, and let's see if we can address some of these concerns and issues. First is from a colleague who has a son with multiple food and seasonal allergies, most recently an outbreak in February in Germany. Allergy tests were performed there. The youngster takes quercetin grapeseed extract, but still has symptoms of rhinitis, itchy nose, eyes, and cough, and would greatly appreciate any therapy suggestions or treatments that make sense. Well, first we would want to know of the nature of the tests. Most food and chemical allergy tests are skin or RAS tests. They measure only type 1 intermediate, but then there are the delivery. Now the next question is, which quercetin and which grapeseed extract was this youngster taken? Because most quercetins and most grapeseed extracts have very low functionality, very low bioavailability. We recommend quercetin dihydrate and low molecular weight soluble OPC as preferred sources. And we have those as PERK Pain Guard, PERK Repair Guard, and PERK Way Guard Repair. So while quercetin and grapeseed extract are generally useful, the forms matter a lot. Quercetin dihydrate is the preferred out of many thousands and thousands of flavonoids. The preferred form from our point of view, both for safety and effectiveness, is quercetin dihydrate. And then the low molecular weight soluble OPC. We would recommend using the LRA by ELISA-ACT test and the plan to find other causes of delayed hypersensitivity. Now, clinically, you might say to me, gee, rhinitis, itchy nose, and eyes, and cough, doesn't that sound like histaminic reactions? And they are. And most histaminic reactions are type 1 intermediate, but some histamine reactions are amplifications of delayed hypersensitivity, the so-called late phase reactions. And that's why in this case I would recommend the LRA by ELISA-ACT test and following the plan to substitute for the reactive items an alkaline-forming diet, a health-promoting diet, a tolerance-restoring diet, a digestive competence-enhancing diet, and then we go by results. The next question is, do we still consider the best pH self-help estimate to be from first morning urine after at least 6 hours of sleep? And the answer is yes. If you want to know about metabolic acidosis, if you want to know about excess acidity in the cells that can wear you out and wear you down, we would recommend strongly checking first morning urine pH as an assessment tool, as a predictive index. Now, yes, you can do venous blood gases. You can do 24-hour urine collected under oil. You can do cumbersome, complicated, difficult to perform studies, and that always is an option. But we would recommend doing the doable, doing the available, checking the first morning urine pH after 6 hours of rest as an excellent tool for determining the metabolic acidosis status. The next question is about a 47-year-old woman who took Levaquin for tendinitis and developed total body weakness with severe tendon pain in 2009, became wheelchair-bound in 2009 and 10, and while now able to ambulate is limited. She lost weight and bone during this period, has a high-stress profession, a low DHEA, and a high cortisol, now is on HRT or hormone replacement therapy with saliva testing, and the question is this Levaquin reaction related to drug-induced liver damage? Can it be reversed totally? How helpful would the ELISA-ACT program be for this woman? Well, first of all, the molecular mechanism by which Levaquin induces the adverse reaction is not fully known. It is clear that Levaquin inhibits fibroblast proliferation. And now fibroblasts are first responder cells, they're repair cells. When we inhibit the proliferation or the replication of fibroblasts, we could be fundamentally inhibiting the repair mechanisms of the body. So colleagues like myself have not used antibiotics like Levaquin for many decades because this effect is known, and to the best of my knowledge, there is no treatment that has a high probability of success. Would I restore hormonal, neurochemical, and immune competence in this individual and go by results? Yes, I would. So I think doing the ELISA-ACT program, following the LRA by ELISA-ACT test makes sense, and seeing if the program achieves further remission and rehabilitation. recognizing that several years after a Levaquin toxicity may be difficult to reverse. Now a question the question is, aside from gout, nephrolithiasis, and known G6PD deficiency, are there any other conditions or medications where a vitamin C cleanse is not medically safe? Important question, very common question. Let's look at it in sequence. First, gout. Gout is known to be a precipitation of uric acid crystals in susceptible joints, but what's interesting about gout is if you have metabolic acidosis behind the scenes, you are about 100 times more likely to have a gout attack than if you are alkaline, but with the same level of uric acid crystals in your joints and the same level of uric acid in your plasma or in your blood. So actually, gout is not a contraindication to ascorbates, because properly given ascorbates and other repair-stimulating molecules help maintain the alkaline healthy status of the joint, reduce the chance that any uric acid will precipitate out, and if it does, and the first responder cells, the fibroblastic kinds of cells, are active, they can recycle. So it is generally said in conventional medicine that people with gout might be more at risk of taking ascorbate to precipitate an attack. And the only source for that I can see is that many people used to take ascorbic acid, and ascorbic acid is by definition an acid. And I did say that metabolic acidosis underlies and amplifies the potential for a gout attack. So we would never use ascorbic acid, as you know. We do not recommend the use of ascorbic acid. And this might be an indication of why using ascorbic acid would not be a good idea. That is, adding acid to a metabolic acidosis condition is contraindicated from my point of view. When we talk about the buffered ascorbates, the per-potent C, and its use in vitamin C cleanses, we have used this with many people with a history of gout. We have not had any gout attacks precipitated, and actually we've had people report that they're less likely to be at mercy of gout when they stay alkaline and when their immune system is confident. Next question is about nephrolithiasis or kidney stones, and the treatment for kidney stones is hydration. The first and most important thing about people at risk of kidney stones is that they must drink enough water to keep their urine dilute so that they won't form additional stones. What is interesting to me is that because ascorbate binds calcium and other divalent cations, you can slowly dissolve many kidney stones through the use of buffered ascorbates and good hydration. So if you're concerned about kidney stones, you want people to be well hydrated. If they're at risk of kidney stones, you want them to be well hydrated. If you're concerned about nephrolithiasis and kidney stones, you want good hydration in the patients. We have a hydration self-test to make sure that people know that they're well hydrated. And then the chance of a kidney stone goes to 0. That's what I was taught by the experts in kidney stones. You can only form a stone when the urine is concentrated. If you keep the person well hydrated so the urine is dilute, you will not form new stones. And actually, if you have ascorbates present, you can slowly pull the matrix out of the stone and slowly dissolve it. So nephrolithiasis is not, or kidney stone risk is not, a contraindication to a vitamin C cleanse or to the use of buffered ascorbates. Now, with regard to G6PD deficiency, people who are truly G6PD deficient have more rigid membranes that makes them more susceptible to certain stresses, including free radical and oxidative and osmotic. And so if you actually have a patient with G6PD deficiency documented, and you want to use ascorbate safely and effectively, please contact me or any other experienced clinician who has worked with G6PD patients before. There are certain in vitro or test tube tests that can be done to determine if the person is sensitive to ascorbate or not. And if you can confirm that they're not, then it benefits them. And if they are, then it should not be used. You're welcome to contact me for further information. So neither gout nor kidney stones are contraindications. G6PD is a bit complicated, and I'm happy to talk with individual clinicians about individual cases and how to safely and effectively have the protective benefit of the ascorbates without risking damage to the cells that are more rigid because of the G6PD deficiency. Next question is about the paleo diet. It seems to be similar to the alkaline whey diet, and with our interest in food sensitivities, there seem to be overlapping components and advantages. What is my comment? And my comment is that in common, both approaches emphasize whole foods. They do have in common the emphasis on a whole foods-based diet. The difference is, however, that a paleo diet is richer in high-protein, high-fat foods, richer in meat, fish, eggs, and fatty foods, foods that hunter-gatherers might have eaten. And we do not recommend it simply because of the fact that the dominance of high-protein, high-fat foods leads to a net acid excess and eventually to metabolic acidosis. In contrast, the alkaline whey recommends 60 to 80% of what you eat should be alkaline-forming, mineral-rich, antioxidant-rich, buffering capacity-rich, and the remainder are the high-protein, high-fat foods that become condiments rather than staples. So what is a staple in the paleo diet is a condiment in the alkaline whey diet. We recommend the alkaline whey diet because in the most comprehensive approaches we know, it provides the most clinical and evidence-based outcome approaches. So there's an additional subtext, which is, where today can we find animals that are truly omega-3 fatty acid, good fatty acid rich in their meat, the way animals thousands of years ago who ate green plants primarily would have been omega-3 rich. If you can find an animal today that's actually been grazed and documented to be as omega-3 rich as was true a few thousand years ago, I think that's an advantage. I do, however, recommend a sustainable diet, the alkaline whey, rather than the paleo diet, the high-protein, high-fat approach, based on the evidence as I know it, and certainly on the clinical results as we've seen them over the last few decades. Now, the next question is about patients and comprehensive allergy testing. A patient recently had 3 items that were described as being, quote, virtually everywhere. This was very frustrating for the patient, led to a sense of despair that nothing can be done for her many symptoms of joint pain and gut issues and migraine headaches. And then the question is, which tests should be done? Which tests were done? Were they rest and skin tests for type 1? Were they true lymphocyte response assays for comprehensive delayed allergy testing? The delayed allergens are likely to be prominent in these cases. We do view it as a window of opportunity to substitute so that you can lower the load in a comprehensive way. Lower the load on the immune system below a threshold so the body can repair, renew, recycle, and reset itself to tolerance. When you enhance digestive competence, when you lower the workload on the immune system below that threshold, the body can recycle. So we would want folks to know that you don't have to be perfect all the time. This was something we worked on and worried quite a bit about early in the days of the laboratory. Because in order to reset the immune system, it might be that you'd have to be near 100% perfect on avoidance and substitution, nearly 100% of the time in order to get the immune system to reset. And since humans are not capable of that kind of attention and perfection, we asked ourselves the question of whether substitution that lowers the load was sufficient to reset the immune system to tolerance as part of an overall program to restore digestive competence, neurohormonal balance, and the like. And to our pleasant surprise, in the initial studies we did, we found that when you do substitute carefully, when you do your best to substitute, that is sufficient because it lowers people below their adaptive capacities, and then the body can restore what it was always able to do, which is recycle a small amount of foreign material. So we think communication and understanding is very important. The understanding that substitution and windows of opportunity are preferred and possible. Next question is about the vitamin C cleanse protocol and how to do it. And here we recommend that you look at the PDF that's online. This is at www.perque.com/PDFS/PT_ascorbate_slush fin.pdf. And what this shows is that depending on how well or ill the person is, you would every 15 minutes take graded amounts of buffered ascorbates, the potent C-Guard, until you have an evacuation or a cleanse reaction that, as extra fluids and extra toxins, flush out of the body. In terms of adrenal restoration, we'd recommend also a PDF that we have online, and that's available to show you that you can rehabilitate and restore adrenal function. We have a whole research study to go over with you, and I only have a few minutes in this Q&A time, but would recommend that you take a look at the website, take a look at the adrenal study that we did, showing that if you have an overly active, excessive cortisol response in the morning, you'll come down. But if your cortisol is too low in the morning, you'll come up. And even if your cortisol is within the usual range, your rhythm will get better. So you have a tropho-restorative and adaptive regenerative capacity of PERC adrenal distress guard to bring high adrenal reactivities back down to a moderate level, bring low exhausted reactivities supported back up into a healthy level, and improved rhythm for people who have usual responses of cortisol and DHEA. So we recommend doing the vitamin C cleanse protocol. We recommend doing the adrenal restoration rehabilitation protocol. We have those available on our websites in detail, and we recommend those to you. Now, the third question was about distinguishing tests for food allergies between IgE and IgG. The IgE tests are for immediate reactions. They're the ones that are triggered by histaminic amplifications. These are the Ishizaka antigens, as they used to be called. And they have reactions that occur within seconds to minutes after the exposure. In contrast, LRA for delayed tests, the lymphocyte response assay for delayed allergies, can determine the food or chemical environmental substances that are inducing burdens on the immune system, and that puts them in contrast to the IgG tests, which are non-functional and can be misleading. The IgG test look for antibody of a memory kind, antibody that sticks around a long time. The problem with IgG antibody tests is that you don't know if they're protective, neutralizing, and helpful, or if those specific antibodies are harmful, complement fixing, and symptom provoking. What you want is to identify the harmful antibodies and not the helpful antibodies. An IgG test is incapable of doing anything except detecting the antibody. It doesn't give you the function or the helpful versus harmful nature of that antibody. That's why you need a cell response assay, because the lymphocytes respond only to the harmful antibodies and they do not respond to the helpful antibodies. So IgE testing for immediate food allergies, yes. IgG testing, no. LRA for delayed allergy testing, LRA by ELISA Act, as the way to get comprehensive and predictive measures of food chemical delayed reactions. Here's a question about a patient who's had a renal transplant. They have a low DHEA and adrenal fatigue. And the question is about using PERC adrenal distress guard, but wants to make sure that it's safe for that individual because of the transplant, and what recommended doses would I suggest? Well, as long as the kidney is functioning well, the individual can take usual adult doses of PERC adrenal distress guard. Fortunately, PERC adrenal distress guard is tropho-restorative. It's adaptogenic. And what that means is that it supports healthy adrenal function. It doesn't force or compete for adrenal function. So as long as the kidney transplant is working, usual adult doses of PERC adrenal distress guard should be helpful. If, however, the kidney transplant is not functioning well, if kidney function is impaired below a GFR of 25 mils a minute, if the glomerular filtration rate is 1/4 or less of usual, and the person is either on dialysis or a candidate for dialysis, then the metabolic or nephrologist specialist who's taking care of that patient we would welcome them talking to our team about how to adjust the dose as you would for any water-soluble molecule based on the reduction in glomerular filtration rate. Let's see, what else? Another question about choline citrate. Is choline citrate the same as phosphol 900? And then what is choline citrate and how does it compare to CDP choline? Well, choline citrate is not phoscholine. Phoscholine is phosphatidylcholine. That means a fat molecule and about 15% of choline. So phoscholine, or phosphatidylcholine, is a way of getting choline, but it's a very expensive way of getting a little bit of choline. The reason we recommend choline citrate is it's a much more valuable, much less expensive way of getting a much more concentrated choline with the citrate carrier that allows its uptake to be enhanced. Now, CDP choline is enhanced by about 50% in terms of its bioavailability. So it's 2 to 3 times enhanced over usual choline, the choline bitartrate that is commonly used. Now that's in comparison to the 100% uptake of percholine citrate, or 4 to 6 times usual uptake and bioavailability. So while CDP choline is better than choline bitartrate that we would never use ever, it is about half as available as percholine citrate, and the reason we recommend percholine citrate is because it's even more available, dramatically so, than the CDP choline. The next question is, how is KPA DHA Guard different from others, other than that it is distilled, that it's the non-rancid pharmaceutical grade, and it has no metals? Now, that already distinguishes KPA DHA Guard. There are third-party post-production tests done on every lot to verify that the EPA DHA has been protected, that it is available, that it has not been oxidized, and in addition to having the highest concentration of active EPA DHA, it has the lowest concentration of everything else. It uses pharmaceutical-grade ingredients always, not when it's convenient, and it is heavy metal free because it's distilled and distilled under nitrogen. It is a kosher soft gel. And so KPA DHA Guard is differentiated or distinctive in that it's distilled under nitrogen, that it has the most actives and the least non-actives, and it is free of the toxic metals that often contaminate these fish oils. And it is in a kosher soft gel. Then a question about why PERC uses MK4, that variety of vitamin K2, in the PERC Bone Guard Forte product instead of MK7. Well, MK7 is a more recently introduced vitamin K2 form. It's a fermentation product from soy by the organism Bacillus subtilis. Since all PERC products are soy-free, the MK7 is not a candidate to be a PERC product because it is sourced from soy by fermentation, and there are soy antigens that remain after the fermentation in the product. So PERC uses K1 and K2 for the best balance of vitamins K in both the multi, that is the PERC LifeGuard formula, and in the PERC Bone Guard Forte formulas. Both K1 and K2 are represented in the pure and more available forms for them. The MK7 has recently been introduced. It is well marketed, but because it's a fermentation product of soy using the organism's Bacillus subtilis, it doesn't meet the quality criteria for being a PERC ingredient. Now, PERC MitoGuard Plus. Please explain why PERC prefers the ubiquinone form of CoQ10 instead of the ubiquinol. Well, ubiquinol is 3 times better absorbed than standard CoQ10, to its credit. However, it must be converted back to ubiquinone in the body in order to be active. So ubiquinol is not the active form. Ubiquinone is the active form of the electron shuttle that gets into the mitochondria. Now, PERC MitoGuard Plus is 3 times better absorbed than the standard CoQ10, and it's active immediately in the body. So since we have uptake that's as good as the ubiquinol, But we don't have to convert the ubiquinol back to ubiquinone because we have the active form that gets in as well as the ubiquinol. Perc MitoGuard Plus contains the ubiquinone, not the ubiquinol. So you have as good an uptake because of the micellization process, and then you have the added bonus that Perc MitoGuard Plus includes the tocopherols, the vitamin Z. Because if you need coenzyme Q10, you also need tocopherols. If you need extra electron shuttling, you need extra electron shuttling in your membrane as well as in your cytochrome. And that's why Perc MitoGuard Plus includes the ubiquinone form, but micellized and enhanced for uptake by the rice bran oil and the micellization process that we use, as well as the added bonus of the tocopherols to add benefit to protect the membranes. Now, a question about the folate in Perc products. Is it natural? And can it be used by people who are MTHFR deficient? Well, Perc does use the natural forms always. That means the 8 natural forms, which are better from our point of view than the one downstream MTHFR form. Those with the MTHFR genotype do need more folates, but they don't need just one form. They actually need all 8 forms. And the MTHFR was developed, synthesized, and patented by Merck to be used in chemotherapy, where the chemotherapy inhibited folate, and they were able to find a downstream form of folate that would get around the block. But that downstream form of folate didn't go back upstream metabolically, so it didn't inhibit the chemotherapy. So the MTHFR is a downstream one of 8 forms of folate. We think people need all 8. And we think that people with that SNP or that genomic expression need more folate to bring their homocysteine down to a healthy level of less than 6. And we recommend using as much folate and as much methylation factors as needed to bring the homocysteine into a healthy level. And yes, people with the MTHFR can also use the Perc products that contain all the natural forms, not just the single downstream form. Now, what are the differences between MELISA and the LRA by ELISA ACT test? Well, MELISA does use lymphocytes as the LRA by ELISA ACT does, but MELISA uses washed lymphocytes. And those washed lymphocytes are then resuspended with radioactive material and incubated for several days to see how much radioactive thymidine or how much radioactivity is taken up by the T cells as they go through mitosis or division. The contrast is that the LRA by ELISA ACT is an autologous cell culture. So we use the patient's own plasma to incubate the cells. We include the antigen-presenting cells, B and T cells. We include the platelets. We include everything except the red cells in the incubation environment, just as it happens in the body. That's why it's an ex vivo test that measures both B cell and T cell reactions, whereas MELISA is an in vitro procedure that measures only T cell reactions. They're similar in both using lymphocytes, but one isolated lymphocytes measuring only T cell reaction, the other an autologous cell culture measuring both B and T cell reactions, LRA by ELISA ACT being more comprehensive. Now a question about the best tests for gluten sensitivity, celiac, and gluten intolerance, and particularly in relation to the LRA by ELISA ACT tests. Well, my first comment is that serology, or standard antibody test for celiac syndrome, are screening tests. You can get an indication of risk. You can't get a diagnosis from an antibody test. Small bowel biopsy is necessary for diagnosis. And celiac syndrome, or celiac disease, is quite different than maldigestion-induced gluten intolerance, or from gluten hypersensitivity, delayed allergy response to the gluten. If you actually have celiac syndrome, then meticulous avoidance of gluten clinically is often recommended for life. What we find is that people can rehabilitate and regrow their small intestine. And when maldigestion is overcome, when enteropathy is reversed, when the immune system is reset, then the celiac person may be in sustainable remission. The contrast is that the person with simple maldigestion and therefore intolerance to gluten needs to have their digestion rehabilitated, but they do not have an autoimmune condition, and they do not need to avoid gluten for life. And then the last group, those that have gluten hypersensitivity, may have other delayed allergies, and a comprehensive approach, as we offer through the LRA by ELISA ACT test, can identify what needs to be substituted, what are the reactive substances, and what is the program, alkaline diet, targeted supplementation, mental and physical activities that will stimulate repair, stimulate restoration of tolerance, stimulate the repair mechanisms in the body. So for autoimmune conditions like celiac, there is value in doing the LRA by ELISA ACT tests, although the rehabilitation is a very long and cumbersome one. In contrast, gluten maldigestion and gluten intolerance can be overcome by correcting the digestive disorder, and gluten hypersensitivity can be overcome by resetting the immune system to tolerance, as we would recommend through the LRA by ELISA ACT test and plan. Question about explaining type 3 and type 4 sensitivities. What are the symptoms exhibited by immune complexes in contrast and comparison to T-cell mediated reactions? Well, type 3 reactions are immune complexes. Arteritis, particularly temporal or regional arteritis, is the classic example. Immune complexes mean that you have an IgM antibody reacting against an IgG antibody with an antigen stuck to it. So if you have antigen coming in and an active or reactive or harmful IgG antibody, and those antibodies need to be cleared by the liver or the spleen each time that the blood goes through the liver or the spleen. If there's so much immune complex that the liver and spleen cannot clean them all, clean the cells off, then you begin having destruction of cells and potentially destruction of endothelial linings, the classic arteritic condition. Type 4 are the T-cell imbalances, Th1 excess or Th2 excess. There are a host of autoimmune conditions associated with imbalance of Th1 or Th2. What healthy people have is a balance of Th1 and Th2 reactors, not too much of one and not too much of the other. From asthma to eczema, from multiple sclerosis to ulcerative colitis, there are a variety of Th1 and Th2 imbalances that are being increasingly studied in conventional medicine, and we believe will be found to have their solution by resetting digestion to competence, by resetting the immune system to tolerance, and by resetting the neurohormonal system to resilience. Here's a question about an individual who had 150 ascorbate cleanses, but still has digestive issues, bloating and constipation, a day or two after. This is despite taking 9 Perk DigestiGuard and 6 to 8 Perk EnduraPAC-Guard for the last 5 months. What are the suggestions? And explain about the 6 hours rest prior to the ascorbate cleanse. Well, yes, it is important, answering the last question first, it is important that the individual have 6 hours of rest to allow the cells in the bladder to equilibrate with the urine, so that when you measure the pH of the urine, you're actually getting a measure of the cellular metabolic status. Now, the 6 hours of rest include the fact that you can get up, go to the bathroom, and then go back to bed. And as long as you are resting, the cells will equilibrate. If you get up and you go to the kitchen and you're active, that's different. So you don't have to be asleep. You don't have to have perfect rest. You just have to be in bed and resting. That includes being able to go to the bathroom and go back to bed, and getting meaningful measure of that first morning urine pH, and also for the ascorbate cleanse. Now, when an individual has persisting digestive problems, we would start with the DigestiGuard and EnduraPAC-Guard, DigestiGuard probiotics, EnduraPAC recycled glutamine, probiotics, the good bugs to displace the bad bugs, recycled glutamine to energize and repair the intestines. If bloating or constipation remain, then we would add Perk Regularity Guard. The goal is to have 40 to 100 grams of fiber a day. If you have less than 40 grams in your diet, which is common, we'd recommend Perk Regularity Guard, anywhere from 1 to 4 doses a day, but making sure that at least 40 grams of fiber are present, both for bulk and to bind toxins. We'd also recommend that the individual be checked for delayed hypersensitivity reactions because while the ascorbate flushes out extra toxins in water when you have enough of the ascorbate on board, there are delayed allergy reactions that can continue irritation in the gut even when you're doing the ascorbate cleanse and taking the DHA Guard probiotics and using the recycled glutamine, the Endura pack.